All right, for this PowerPoint, we're going to be discussing anti-seizure medications first. Let's talk about what classifications of seizures or what these mean. Generalized seizure begins in one part of the brain, but then it spreads throughout both hemispheres. We think of the classic seizure picture of the tonic-clonic dramatic muscle contraction seizure, and that is a part of a generalized seizure. But there's other types. There's absence seizures, myoclonic, Jacksonian. So there are different types of generalized seizures. Partial seizures, they involve one area of the brain. They could be a simple partial seizure, which just, again, single part of the brain, involves like a single muscle movement or sensory alteration. But they can also be complex. Some meds that we give for seizures, one of the common meds that you'll see is phenytoin, also known as Dilantin. This decreases conduction through the nerve pathways. That's its action. It's used for generalized seizures and status epilepticus. Remember, status epilepticus is that seizure that lasts longer than 5 minutes, or multiple seizures, one right after another. We talked about this with benzodiazepines. Benzodiazepines are a common treatment for status epilepticus. In fact, anytime I've treated status, it's always been a benzo first and then follow it with something such as Dilantin. A lot of times, though, that right now treatment is your benzodiazepine, such as diazepam or lorazepam. Adverse effects, so we're slowing nerve conduction, so CNS depression is what we need to think about with these. So again, fatigue, dizziness, lethargy, drowsiness. They should not operate machinery when they're on these meds. Another common adverse effect is gingival hyperplasia. That's an overgrowth of the gum tissue. It's really important for these guys to practice diligent oral care. They really need to make sure they have good plaque control in order to try to reduce the risk of this side effect. And then hirsutism or unexpected hair growth is another possible adverse effect. Contraindications, you'd be careful in arrhythmias. Liver disease, these can cause some liver problems. So if they've already got liver disease, it's one of those things, what's the level of liver disease or liver problems going on there. Another contraindication would be pregnancy or lactation. So, and then cardiovascular disease, again, a caution / contraindication. Interactions, they interact with oral contraceptives, so women should use barrier contraception. CNS depressants, of course, because that's one of the major side effects. And then they can interact with other seizure medications and alcohol, which we talked about with the CNS depressants. Patient teaching. A lot of these seizure medicines need blood work to monitor levels. This is one of them. Again, we might want to make sure that they understand this is not a cure. This doesn't cure your seizures. It just hopefully controls them. That's the goal anyways. We want to make sure we really hit home the importance of frequent oral hygiene. Avoid activities that require alertness, again, because of that CNS depression. And of course, avoid pregnancy. And along with that, these can interact with oral birth control, so they'll probably need to use barrier protection. Barbiturates, another medicine that's sometimes used for seizure control, especially status, but also, for some people will need them for just their seizure activity. The thing about seizures is, some people can be controlled with one drug, some people need multiple drugs, some people, we just kind of got to find out what's going to work for them. These work in the reticular activating system, and they help inhibit those impulses to bring the seizure activity down, and that's their indication: seizures and status. Again, we use these a lot of times for status epilepticus, and then we also will use these for sedation because these are good at sedating. Sometimes these are used in order to get that sedation. Your adverse effects, again, CNS depression, since we're slowing those nerve pathways down. However, you may see a paradoxical effect in children. You may see, instead, we expect to see sedation. You may see stimulation in children. These also have the potential for toxicity. That's the signs and symptoms of that are usually pinpoint pupils. You'll see that. And then it can progress to respiratory depression, coma, and death. For an overdose, there is not really an antidote. We use like activated charcoal and respiratory support through an ET tube. And we use fluids for hypotension. So we just try to support them to get them through it. It's contraindicated, of course, in respiratory dysfunction because of that potential effect on respiratory depression. And be careful in people with depression. Interactions, any other CNS depressant, and again with the oral contraceptives. So they're going to have to use barrier protection. They would want to avoid pregnancy when they're on these. So patient teaching, again, avoid pregnancy, use barrier protections. They're going to probably need blood work to monitor their levels. This is not a cure. It's just going to help control seizures, but it will not cure them. And then, of course, avoid activities that require your alertness because of that CNS depression. Benzodiazepines, we talked about these with the last lecture. Let's talk about them again a little bit more here. Diazepam, clonazepam, lorazepam, all those are benzodiazepines. These work to potentiate GABA, right? That's their action. They decrease CNS excitability, stabilizing nerve membranes, and they do that through GABA. So the indication of these, status epilepticus, and then you will sometimes see them for those severe recurrent seizures. It's not normally for seizure control, though a lot of times it's just for that status. And again, these are a lot of times the initial medicine we give for status. So people will have these at home for those instances. And then think about it, if they are in a seizure, if they're currently seizing or currently in a seizure that lasts longer than 5 minutes, or those multiple seizures, it's obviously not going to be safe to give that to them orally. So in the home, a lot of times these will be given rectally. So just kind of keep that in mind. Other drugs for treating seizures, carbamezapine, valproic acid, levetiracetam. I mess that one up every time. That's also known as Keppra. Keppra is one of the only ones that I've found that they'll use through pregnancy. The others you try not to use through pregnancy. But the Keppra or the levetiracetam, it is the one that you will see a lot of times through pregnancy for those that are those seizure patients that are pregnant. These all work in various mechanisms, so we won't go through each of them, but these ones are used primarily just for the general or partial seizures. These aren't status medicines. These are just control medicines. Adverse effects, again, those CNS effects, blurred vision, dizziness. These are associated sometimes with Stevens-Johnson syndrome. That is a severe rash. Affects the skin and mucous membranes, and you actually slough that off. That can be life-threatening. It's associated with multiple meds, antipsychotic meds, analgesic meds, even like acetaminophen and ibuprofen can be associated with Stevens-Johnson syndrome. And it can also be caused by infections like herpes, pneumonia, Hep A. But anti-seizure medicines are one of those classes of medicines that can sometimes cause this. So we'll definitely want to inform them to watch out for rash. These can also cause some bone marrow suppression and some liver involvement sometimes as well. Again, a lot of these are contraindicated in pregnancy. However, like I said, levetiracetam, that is the one that I've seen traditionally used for those that need control through pregnancy. Be careful with bone marrow suppressions. Of course, it's going to interact with other anti-epileptic drugs. Our patient teaching: take as prescribed. Of course, avoid pregnancy. Discuss other prescriptions and OTC medicines with their doctor. We'll want to warn them about that rash. If they start noticing a rash occurring, notify the provider. And with a lot of these, again, they'll need periodic lab work. Anti-Parkinson medicines. So Parkinson's disease. This is a progressive chronic disease. It's a neurological disease. There's no cure for it. We only hope to stave off symptoms or control symptoms and stave it off as long as possible. But it leads to degeneration of the dopamine producing cells. That's in the substantia nigra. That's a portion of the brain that releases dopamine, I'm sorry. And this disease destroys that area. So we have progressive loss of coordination and function. It's the classic symptoms of it are lack of coordination. You get those tremors. You get trouble just performing intentional movements. It's like extremely slow, very sluggish. You get that mask-like expression, that shuffling gait. The actual cause, we're not 100% sure, but we do know that it's related to that damage, those damaged cells there in the substantia nigra. And again, the neurotransmitter that's affected, of course, is dopamine. So the gold standard medication for this is carbidopa-levodopa. It's also known as Sinemet. These two are together because the carbidopa, the levodopa is the actual dopamine. Once it gets into the body, especially up into the brain, it's converted into dopamine, and then you're able to utilize that. The problem is to get this drug past the blood-brain barrier is extremely difficult. You got to give a pretty high level of it. So what carbidopa does is it helps keep it from breaking down until it gets across that blood-brain barrier. So it's almost like it puts it on its back and runs it through that blood-brain barrier and gets that way it can be effective. If without the carbidopa, you've got to get a large amount of levodopa in order to get the same results. So carbidopa just allows us to give you less levodopa, which is good because the side effects of levodopa can be significant. So that's what carbidopa's role is. There's other meds, the ropinirole and amantadine. Those are sometimes also used for this. They're really symptomatic relief. The amantadine can increase dopamine and can block reuptake of dopamine, but the gold standard medicine is still Sinemet. And so that's the action. Again, increases dopamine levels and to stimulate those dopamine receptors. And our indication, of course, is Parkinson's disease. Adverse effects, dyskinesia, that's that difficulty with performing voluntary movements. That is like when you see Parkinson's patients and they have those kind of abnormal movements. If you think about Michael J. Fox recently when he does interviews, he's kind of got those tics. A lot of those tics are involved or are there because of the meds, really. Yes, Parkinson's can lead to some of that, but a lot of it is the meds that you see. That also can cause drowsiness, nausea, vomiting, orthostatic hypotension. There can be some psychosis involved with these. Back in the day, they used to associate these with melanoma. Recent research shows that that may not be as direct as they think. However, if a person has melanoma, we need to be very careful with these medicines. So contraindications, again, if they have melanoma, if they have a history of melanoma, it's going to be a risk-benefit type thing, but they need something. And then certain types of glaucoma would be extremely careful, or could potentially be contraindicated depending on what's going on there. You'd be really careful in people with hepatic impairment, cardiovascular disease. And if they had psychiatric disorders, we'd be really careful there, because a lot of the treatment for those are things that block dopamine, which would be the last thing we want to do. So that's our interactions. Our antipsychotic medicines, especially the typical antipsychotics, also can interact with MAOIs, which makes sense. In fact, you can't use MAOIs for 14 days prior to starting your Parkinson's medications. So you would have to stop the MAOI for 14 days before starting this, and vice versa. I don't see why anyone would go off their Parkinson's to go onto an MAOI, but if that were the case, you'd have to stop for 14 days. It can also mess with vitamin B6. It can decrease, the vitamin B6 itself can decrease how effective levodopa is, can interfere with that absorption. So they wouldn't want to take that. Protein as well. So they shouldn't take this with a high protein diet, because that can also interfere with the absorption of levodopa. Patient teaching. The goal is to provide symptomatic relief. It may take several months, though, to start noticing effects. It's not like they take it and the next day they feel great. And in fact, they have periods of wearing off, and they'll have to readjust their medications. Eventually, though, those cells will get destroyed to a point where even the meds aren't really going to be able to help much. There's no cure for this. This, again, is just helping to maintain the person as stable as possible throughout the progression of the disease, but eventually it will progress to a point where the meds aren't going to do much. Can cause dizziness, drowsiness, of course. Again, the benefits diminish over time. Do not take it with a high protein meal, and do not take vitamin supplements. We do use anticholinergic medicines sometimes to help with some of those symptoms. Benzodiazepine, that's Cogentin. That's one of the ones that I've seen most commonly. This blocks the action of acetylcholine, which we know because it's an anticholinergic. The thing is with dopamine and acetylcholine are supposed to be level in our system. We're supposed to have a level balance between the two. Obviously, with Parkinson's, now your dopamine levels are lower and your anticholinergic, your acetylcholine is higher. That can cause a lot of problems. So this just tries to level that out. So it helps with a lot of those symptoms associated with Parkinson's disease, and that's our indication. Adverse effects. Well, the common anticholinergic effects: can't see, can't pee, can't spit, can't poop. You'll also see some nausea, vomiting. These can potentially cause these can also cause some drowsiness. It'd be contraindicated in BPH, just like any other anticholinergic or any sort of urinary obstruction. Be careful with glaucoma. Again, probably contraindicated depending on the level there. It'd be really careful in people with cardiovascular disease. It's going to interact with other anticholinergic medications. Patient teaching. Take medicine at the same time each day. With Parkinson's meds, it's really important to keep them on their schedule. So if you get a patient that's been admitted with Parkinson's and they're on medications for it, we need to ask them what their schedule is at home, and then we need to contact the pharmacy and get them to put that in the MAR exactly as they take it at home. It's really important for them to stay on the same schedule. And usually most of the people I've taken care of, they've been very on top of that. Like, hey, I need to make sure I'm taking this medicine at this time, this medicine at this time. So they usually keep you honest on that stuff. But just try to remember, anytime you get a Parkinson's patient, ask them what their schedule is for these meds, and try to maintain that schedule as close as possible in the facility. For the dry mouth, they can use sugarless candies or gums. That'll help sometimes. Increase fluid intake, of course. One thing for Parkinson's in general is just be active. The more active you are, the slower the progression seems to be. And so we're also going to help them maintain their independence with their ADLs. Cholinergic agonists. So myasthenia gravis. This is a disease state where it's an autoimmune disorder. Your antibodies attack acetylcholine receptors. Leads to weakness of skeletal muscles, fatigue, dysphagia, ptosis, respiratory muscle weakness. The biggest concern with myasthenia gravis is when you're having an exacerbation, it can lead to extreme weakness and respiratory difficulty. That's when we're going to get real concerned. So some meds that we use: neostigmine, pyridostigmine. The pyridostigmine doesn't easily cross the blood-brain barrier, and it's got a longer duration of action, whereas the neostigmine has a shorter duration of action. But these prevent cholinesterase from inactivating acetylcholine, and we use these again for myasthenia gravis. It's cholinesterase, so acetylcholine in the nerve terminal there, it's released by the nerve terminal. It goes over, it activates the nerve, and then some of it's reuptake back, and then some of it is broken down by cholinesterase. You've got to keep that nerve terminal clean. You can't have too much acetylcholine, because if you did, then you'd have overstimulation. That'd be a really bad thing. But you need some of it there, obviously. This so what this does is it prevents that breaking down in the cleft, right? So we got this cholinesterase goes in, it cleans that out, kind of like an MAO. You remember the MAO cleans out the nerve from the dopamine, serotonin, norepinephrine. Cholinesterase kind of does the same thing. It goes in and cleans out some acetylcholine. It doesn't clean it all out, but cleans it out. This prevents that from happening, prevents the cholinesterase from inactivating the acetylcholine. And that's our indication, myasthenia gravis. Adverse effects, GI distress. Think of anything that's the exact opposite of anticholinergics, right? So instead of dry mouth, we're going to have increased salivation. Instead of constipation, we can have diarrhea. We could actually lead to a cholinergic crisis if you have too much acetylcholine there in the nerve terminal there in the cleft. You can actually have a crisis, and that can be just as bad as not having enough. Contraindicated in GU or GI obstruction, which makes sense because instead of not peeing enough, we're going to pee more. Instead of not pooping, we're going to poop more, right? This can also lead to bradycardia. So be careful with bradycardia, hypotension, asthma. Interactions, of course, anticholinergics, any other anticholinergic medicines. Also NSAIDs, because those can increase the risk when you take those with these medicines, can increase the risk of GI bleed. Patient teaching, these again taken at the same time each day. It's taken multiple times through the day, so they got to stay on their schedule. And then the dosage is adjusted, and it's going to probably need adjustment depending on the patient, whether they're an exacerbation or what's going on with them and their symptoms. Alzheimer's disease is another process that uses these medications. It's a chronic progressive neurologic disorder, leads to severe loss of memory. You just forget how to perform ADLs, progressive loss of acetylcholine, and then especially in the brain, and it just leads to that progressive destruction, loss of memory, forgetfulness of even just how to do anything. Some meds that we use for that, donepezil, you may have heard of it as Aricept, and rivastigmine. These meds, they can help retain memory, but they're only usually good for so long. Their effectiveness definitely varies between patients. They're not even close to being a cure. Again, they're just for, they do help according to research, but the amount that they help is, depending on the patient, is minimal, and it doesn't last that long. From what I've read, you can maybe get another year out of your memory or more, maybe a little bit, but it's not like it's going to preserve them for a decade or anything like that. And their indications: Alzheimer's disease. Adverse reaction with these medicines, again, bradycardia, increased urination, everything that's, if you think of your anticholinergic effects, think of the exact opposites for these. So of course, you be careful with bradycardia, urinary obstruction, people with respiratory disorders. They can interact with NSAIDs and anticholinergic drugs. Again, this is not a cure. Again, it can slow the progression. It's not usually for a long time, but it can kind of slow the progression. And we'll want to warn them that it can cause increased urination. So kind of prepare for that. Anticholinergic agents, we've really talked a lot about these already, so let's go into them a little more. The things we use these for. Think about your classic anticholinergic effects. So they can increase heart rate, right? That's one of those things that can increase. So we use them for bradycardia. Dry mouth, right? That's a common side effect of anticholinergics. Sometimes we use them to decrease secretions. Constipation, another classic anticholinergic effect, and sometimes we use them for that reason, to decrease their GI activity. Urinary retention is another classic anticholinergic effect, so sometimes we want that. Sometimes we want to decrease urinary bladder tone, so we use them for that. We use them sometimes for pupil dilation. We talked about bronchodilation, right? That is one thing that does occur with some anticholinergics. They can cause that bronchodilation. And then sometimes we use them for motion sickness or nausea and vomiting. Adverse effects, your classic adverse effects: can't see, can't pee, can't spit, can't poop. So dry mouth, urinary retention, constipation, blurred vision. Also tachycardia, decreased sweating. Some common anticholinergic agents that we use: atropine. What is it used for? That is bradycardia IV. So if you give this IV, it's for bradycardia, and it's part of that. It's part of the protocol usually for symptomatic severe bradycardia. Ipratropium, we've talked about this med already. That's your anticholinergic respiratory med. That's going to cause bronchodilation. So that's what we're using it for. Meclizine, also known as Antivert, we use that for dizziness. And then scopolamine we use for post-surgical nausea. It goes behind the ear. It's like a little patch. We also sometimes use it for decreased salivation, especially in people on hospice. Atropine is sometimes used for that as well. Atropine is usually drops, though. It's little drops that you put in the mouth, and it helps dry up the secretions to keep those from building up and going down the throat. If you've ever taken care of somebody that's on hospice, you know that kind of breathing. Some people call it like a death rattle. It's a horrible thing to say, but it's true. Like you get that rattle in the back of the throat, just all that secretion build up back there. This helps control that. Scopolamine does that with the patch. Sometimes they'll use that, and sometimes they'll use atropine drops. All right, so meds that we use for the urinary tract, these are antispasmodics. oxybutin or oxybutynin. That's also known as ditropan. And tolterodine is your Detrol. You may have heard of these. They're fairly common. They block parasympathetic activity. They relax that detrusor muscle. They are anticholinergic, and we use these for overactive bladder. That's our indication for these, overactive bladder or bladder spasms. Adverse effects, just your anticholinergic effects, your common anticholinergic effects. And in this case, we want that urinary retention. Contraindication, urinary tract or GI obstruction, uncontrolled glaucoma. Be careful in people with BPH. Interaction, other anticholinergics. There's also antipsychotics. There's quite a few interactions with these. Patient teaching, maintain adequate fluid intake, take frequent sips of water, use sugarless gum and candy.